Hello and welcome back to SWESEM Junior's ECG Essentials. This is part 3 where we talk about arrhythmias, and I would really call this part 3.2. In part 3.1, we talked about supraventricular arrhythmias such as SVT, AFib, and atrial flutter. Today, we'll be talking about re-entry tachycardias and ventricular arrhythmias. So, we're going to start strong and talk about re-entry tachycardias. So, in normal impulse transmission, the depolarizing impulse spreads easy and smooth through the myocardium like a wave. If the impulse meets tissue that is blocked, a re-entry can start. An anatomical re-entry consists of an anatomical structure that blocks the impulse. Anatomical re-entries are very stable and can continue for hours. One example of this is one that we talked about in the previous episode, and that is atrial flutter. In this example, the tricuspid valve blocks the impulse because it cannot be depolarized, and the impulse thus has to go around it. The re-entry tachycardias that we're going to focus on today are AVNRT and ANRT. AVNRT stands for AV nodal re-entry tachycardia. Patients with AVNRT normally describe a sudden onset of rapid, regular palpitations. They can also have dyspnea. The attack can be triggered by different things such as stress, hypothyroidism, changes in electrolytes, and, sorry to say, caffeine. In an AVNRT, the patient has an extra-conducting pathway in or next to the AV node. It exists in people of all ages, regardless of other cardiac pathology. Normally, it starts when an extra beat from the atria arrive at the AV node, with two different pathways. One of them is refractory, and so that impulse takes the other way round. This creates a loop of the impulse that travels back to the AV node. Thus the name, AV node re-entry tachycardia. Now, the most common type of AVNRT is slow-fast, and this means that it has a slow impulse leading down to the ventricles and a fast impulse leading up to the atria. The slow pathway in an AVNRT is anterograde, which means that the fast pathway leads the impulse in a retrograde direction. What that actually means is that the impulse that goes to the ventricles is slow, while the impulse that goes back to the atriums is fast. The fast pathway, which starts at the same time as the slow pathway and leads its impulse to the atriums, will create a P wave, which will be visible directly after the QRS complex in leads 2, 3, and AVF. Sometimes, since both the atria and the ventricles are activated at the same time, the P wave will disappear behind the QRS complex. But in the ECG in front of us, we can clearly see the marked P wave after the QRS. So, summing up our ECG findings, we will see a quick and regular ventricular rhythm of 160 to 220 beats per minute. The QRS complexes are normal because the impulse still travels through the AV node. P waves are often hidden behind the QRS complexes, but may also be visible right after the QRS complex in leads 2, 3, or AVF. This is known as a pseudo S wave, as it mimics the S wave. You may also note the P wave in leads V1 or V2 as a pseudo R wave. So we're going to move on to AVRTs. Now, an AVRT stands for an atrioventricular re-entry tachycardia. This means that a patient with an AVRT will have an anatomical re-entry circuit that is outside of the AV node. These come in two different types. Orthodromic or narrow tachycardia is a re-entry tachycardia where the re-entry circuit goes from ventricle to atrium. Thus, the impulse from the atrium to the ventricle will still go through the AV node. The orthodromic AVRT creates a regular and narrow complex. More than 90% of AVRTs are orthodromic, in conduction, and the treatment is the same as for a regular SVT. Now, the antidromic AVRT is slightly different. It has a conduction that goes down from the atrium to the ventricles in an accessory pathway and back into the atrium via the AV node. This means that it escapes the inhibition from the AV node and can thus act in a similar pattern to a ventricular tachycardia. This is especially dangerous in patients who have a supraventricular tachycardia in combination with the antidromic AVRT. One example of this is patients who have a syndrome called Wolff-Parkinson-White. The typical finding for patients with Wolff-Parkinson-White is a delta wave. The delta wave is in the beginning of the QRS complex and leads to a general widening of the complex. You might also see secondary STT changes. Now, since an antidromic AVRT does not have the inhibition of the AV node to control rate, the rate is usually about 200 to 300 beats per minute. Wide QRS complexes are due to abnormal ventricular depolarization via the accessory pathway. The treatment for this is the same as for a ventricular tachycardia or VF. So moving on to the last topic, I would like to talk about ventricular tachycardia and ventricular fibrillation, so VT and VF. Now, ventricular tachycardia is, as the name suggests, a fast rhythm from the ventricle. This is a potentially life-threatening arrhythmia, and depending on the focus of the VT, it will have different hemodynamic consequences. Now, a focus that is near the septum gives you the same direction of depolarization and contraction pattern as a normal impulse. That means that the hemodynamic effect is smaller. If the focus is, instead, low in the ventricles, it gives an inappropriate contraction with low cardiac output and consequent hypotension. Secondary to this, you get a decreased myocardial perfusion with a degeneration into ventricular fibrillation. What you usually see on your ECG are broad QRS complexes with a deviant appearance. You'll have a frequency of over 100 beats per minute, and there will be no visible P waves. Your VT can be either monomorphic or polymorphic. Now, monomorphic is the most common and comes from a single focus in the ventricle. The classic polymorphic VT is torsade de pointes. The most common reasons for VT are coronary heart disease, heart failure, and cardiomyopathy. And I believe those are the final points that I'm going to bring up when talking about arrhythmias. I don't know about you, but I'm now all out of coffee, and I see that as a sign that marks the end of this episode. Thank you again for listening, and I hope you feel you've learned something new about arrhythmias and how they show up on your ECG.